Hi, I'm Paul Cook. Today I'm going to be talking to Dr. Joshua Bloom, who's a primary care physician at Denver Health and a specialist in opiate medication overuse, and we're going to be talking about that problem as it relates to primary care. So we've been talking to primary care professionals around the state about motivational interviewing for substance use problems. And as mainly we've been talking about alcohol, people have been telling us, I really wish my patients used alcohol. It's really these prescription pain medications that are the challenge for us. And so what I'd like to know is two things. Why do you think this has come to the fore right now, and why are primary care providers finding it to be such a particular challenge?
Well, I think something that's brought the issue to the fore is simply the number of people who are dying from these medications every year. So the death rates have at least tripled related to opioids in the last 10 or 15 years. And it's really affecting people from all walks of life. As of 2014, somewhere near 19,000 people had died nationally from opioid overdoses. And this is a huge epidemic. And I think it's finally hit the mainstream where people are getting aware of the fact that this is killing people who otherwise should have long and productive lives. And I think it's finally hit the public consciousness.
So it's affecting more people than it did in the past, and also sort of a broader segment of society, you'd say?
Absolutely. So there's a lot of people on opioid medications now, a lot more than there used to be. And we know we as physicians are responsible for that. So the number of prescriptions being written for these medications has gone up tremendously in the last couple decades. And there's a clear correlation between that increase and the risk of overdose deaths and other complications related to opioids.
So it sounds like the guidelines really have changed substantially, so patients' perception that they're getting mixed messages may be accurate to some extent. At one point, there was a recommendation that we use more of the opiate medications, and now we're trying to get people off of them and to really cut that back. So what's your thought about how to address patients when they see that tension?
Well, make no mistake, this is a physician-created epidemic. So we were taught as physicians in the mid-90s that these medications are effective and that they're safe with a very low risk of complications and addiction. And now we know that essentially the opposite is true. These medications may or may not be effective, and for many people they're not. And people who take them have the same amount of pain once they're on them as they had before taking them, and in many cases their function is actually worse. And then we know that they're not as safe as we thought they were. We thought the long-acting medications were safe and you could prescribe them with little risk of creating addiction or other complications. And now we know in a small segment of the population there's a very high risk of addiction, and that people who use these medications can get into a lot of trouble. So we've sent the mixed messages to patients. We've sent the message that the meds are safe and effective, and now we're turning around and having to undo some of the damage that we've done by explaining, look, these medicines really aren't as effective as we thought they were, and in fact they're clearly not as safe as we thought they were.
The guidelines have really changed around that. It's now it's sort of, if it's non-cancer pain, it's only a limited use, right? Sort of an acute situation, but nothing more chronic, and that wasn't always the case.
Yeah, the guidelines were never advocating the use of widespread opioids, but what we saw starting in 2009 is that guidelines have gotten progressively more strict in how they've recommended opioids. So the vast majority of practices that we do as primary care providers are not supported by any evidence, and so there's a real lack of evidence in the guidelines. But I think with the amount of harm that we've seen with these medications, the guidelines have gotten stricter and stricter, so that now when you come and find CDC's guidelines that were just released earlier this year, saying we should be limiting acute pain medications to 3 days in most cases, and that we should be limiting opioids to less than 50 milligram morphine equivalents per day. And this is a big sea change from what people were used to doing in practice in the 90s and early 2000s.
Sure. So that is a big change for practitioners to accommodate, and then that's responsible for patients who may have been in care for a while hearing something different now than what they might have heard before.
Yeah, and it really puts practitioners in a really difficult position, because here in the past people would come in and they would say, I have chronic pain, it's severe pain, and we were told by all means prescribe these opioid medications. And it's kind of nice because nothing ends a visit easier than pulling out the prescription pad. So you could write for the chronic pain medication, and the patient would be satisfied and you would be satisfied and you could go on. And now practitioners feel like the rug's really been pulled out from under them, being told, hey, these medicines aren't safe and you need to take all your patients off of them. And that's a very difficult conversation to have. It's a long it requires a long-term relationship with the patient. And it also requires a paradigm shift from, hey, we're going to use this pill to treat your pain, to we need you to have a partnership with us where you need to set your own self-management goals around pain. And we need you to have a much more multidisciplinary approach to your pain to treat it.
Now, maybe because you want this to be in the context of an ongoing relationship, that's something that primary care is very strong at. But it isn't necessarily a primary care practitioner who originally prescribed a pain medication. You know, a patient might come in out of an acute hospitalization, or they've been in care someplace else, and the primary care provider now is seeing this patient and aware of the guideline in the back of their head and trying to make some modification to this regimen that the patient's on. So that puts them in a difficult situation.
Really difficult situation, you're right, Paul, and it also speaks to the need for an ongoing therapeutic longitudinal relationship with the patient. You have to make the patient feel like they're part of a partnership, and then work with them incrementally. So you brought up the issue of legacy patients, these patients who come to primary care providers and they're on all sorts of crazy pain regimens that you realize are not to the standard of care any longer, and you really can't change everything all at once. You have to establish care with that person, know that you are there to help support them, know that you're going to treat their pain and take it seriously, and then work to incrementally ratchet things down and bring things more in line.
So that's something that could be reassuring to providers, that they don't have to change this all at once.
Yeah, I try to teach that you don't have to do everything. You can just incrementally, and you might take a patient who's on, let's say, 240 milligrams of OxyContin a day, and you might eventually get them down to 180, and that's still safer than where they were before. And you might take several weeks to get them down there, and then as you're working down towards that, you're introducing other modalities for their pain management. So you don't have to just suddenly take them off the medicines. You also need to get the patient buy-in. And so if you try to do things too quickly, the patient's not only going to not buy in, they're actually just going to leave your practice. And we don't want patients doing that, because they're not going to be well served, and society and the medical system is not going to be well served by someone who's just going around to other doctors until they finally find someone who may be less responsible than you, who's willing to keep prescribing it at a very high and unsafe level.
I think, that's what you don't want, is to have somebody who leaves and then goes doctor shopping, and they're just going to kind of look around till they get that. You've got to be careful to maintain the relationship so that you're working with this patient on an ongoing basis if you're going to take the pain medication down.
Yeah, I think one of our biggest fears is if you are ratcheting the patient down too much, or you don't have that therapeutic relationship, they will eventually seek out and find the less scrupulous physician or practitioner who's willing to keep prescribing not to the standard of care, who's not monitoring the patient, whose interest is less in the well-being of the patient and more in just getting that person in and out of the office.
Okay. So you mentioned some other treatment options that might be available for patients, and I know there's a variety of things available out there, like meditation or cognitive behavioral therapy, physical therapy. Are there certain things that you find are more acceptable to patients, and certain things that have better evidence that might be able to be used in primary care?
Well, again, providers are put in a really difficult position, because where the focus has been now is on getting people into multimodal pain therapy. But most of us have very little access to that. So
it's a specialized kind of referral, and you have to be in an area that has that.
That has that. And we've seen all those clinics tended to shutter in the 90s and 2000s because the reimbursement models did not support these multimodal pain clinics that had a neurologist and a psychiatrist and a physical therapist and a pain specialist. So providers are left kind of holding the bag with these patients, where the recommendation is apply multimodal pain therapy, and we don't have access to that. So my response, and I think what most of us look for, are ways that we can refer for cognitive behavioral therapy, or just to psychological support, or even do some basic CBT ourselves in the setting of a visit, because it's just not realistic for us to have access to some of those referral resources. But back to your question as to what actually works better, interestingly, even if you look at cognitive behavioral therapy, which has the best evidence of any of the modalities for chronic pain, if you actually look, when you compare it to active controls, CBT has minimal to no effect on pain. What it actually does do, and this is maybe even more compared with waiting list and no therapy, is it improves people's coping. So they have less catastrophizing, they have improvements in their mood, and they have improvements in their function. So what CBT does is it doesn't affect your pain. It just helps with your management of the pain. And I think that's where we are with patients, is explaining to them, look, you're always going to be living in chronic pain. What I'm going to try to do is help you cope with the pain, manage the pain, and have a productive, happy life with the pain or despite the pain.
Out of the conversation that we were having about treatment modalities, what I'm hearing for a rural primary care practitioner, sort of job one is find somebody who can do cognitive behavioral therapy in your neighborhood and you can partner with and have some support in that, but also have some understanding yourself of these psychological principles, because you're going to be working with patients to do more symptom management also.
Yeah, absolutely. I think all primary care physicians and providers need to be at least familiar with some cognitive behavioral therapy techniques, because just like in the same way that we do brief interventions around tobacco cessation or risky alcohol use, we can do those same brief interventions around pain management. So it might be spending a few minutes talking to someone about pleasant activity scheduling or graded activation. These are things that are really amenable to a few minutes where you talk to a patient about scheduling something that's really pleasant and pleasurable for them in the next week, and then going and following up on that. That's really basic behavioral therapy, and all clinicians should be able to manage at least the basics of that.
It's something simple you could do even in a primary care setting in a brief visit. So something that we're hearing a lot about from primary care providers is this medical option called buprenorphine. And that's something that may not be available in all areas, but it is something that prescribers are seeing as a potential help in these difficult situations. Would you comment on that? How well does it work, and what are the restrictions around its use?
So buprenorphine is a great drug. It is very effective as medication-assisted therapy, so replacement therapy for people who have opioid use disorders. So the problem is we've created this epidemic. We now have about 2 million people who have opioid use disorders with prescription medications. That's a chronic disease that is not going to go away on its own. And simply taking a patient off of an opioid prescription is not the same thing as treating that addiction. And so buprenorphine represents a really great opportunity to increase access to medication-assisted therapy for people who just otherwise aren't going to be able to function without opioids now that we've created addiction in them. Buprenorphine is a partial opioid agonist, which means that it only stimulates the receptor to a ceiling effect, and it's very hard to overdose, and it doesn't cause death in the same rate or problem that methadone does. It's also something that primary care physicians can prescribe. You do have to be a physician to prescribe it, with a special waiver from the Centers for Substance Abuse Treatment, which requires 8 hours of training.
So you have to be a physician, let's say not a nurse practitioner, for instance, and you have to go through this 8-hour waiver training.
Yes.
And then a primary care physician could prescribe.
Yes, although if you're a primary care physician and you work in a practice with other nurse practitioners or physician assistants, other people can actually do much of the management around buprenorphine. So they can do all the monitoring and follow-up with the patients. The physician simply has to make the decisions around dosage adjustment and write the prescriptions. But so really, nurse practitioners can be very closely involved in treating a patient with buprenorphine, and that can be a huge help. And knowing that physician time is limited, if you do have nurse practitioners in a practice who have the time to see those patients, it's a great model for getting people off of prescription opioids for pain in someone with an opioid use disorder and putting them on medication-assisted treatment.
So whether it's the more medical or the more psychological, I'm hearing there's a real role for an interprofessional team approach to these patients.
There really is, because methadone clinics are few and far between. They handle just a very small fraction of the people with opioid use disorders. And now that we have these millions of people with opioid use disorders, we need to have something to treat them with.
Okay. So let's talk about something that we wouldn't recommend as a treatment, but that probably is more available out in rural areas, and that's heroin.
Well, and so what happened was in the 1990s, we saw liberalization of opioid prescribing, and that created a whole lot of new users. And at the same time, we saw widespread change in the way heroin was distributed. And so it moved away from the coasts, where it used to historically only be located into the middle of the country and in many of the smaller markets and smaller cities and towns. And that just created a perfect storm where the prescription drugs came in and created a whole bunch of new users and new clients potentially for heroin. And then when those patients were taken off their prescription opioids or could no longer afford to buy street opioids, they turned to heroin inevitably because it was cheap and it was available.
So it's again sort of a cautionary tale for don't just take everybody immediately off the opioids and not give them something else, because the obvious alternative might be the street drug, which is going to be a lot more dangerous.
Yes, and we know that the vast majority of people who use heroin today started with a prescription opioid.
Fascinating. Okay. So it's a pathway to
Yeah,
heroin use.
it's a pathway. Also, many of the people who are heroin users and began with the prescription opioid, many of those people never had the opioid prescribed to them. So when we prescribe to our patients, a lot of times the patients might be using the medications appropriately or they may have legitimate pain, but when that prescription leaves our hands and the patient fills the prescription for the pills, we don't know what's happened to those pills eventually, and a lot of times a small number are diverted. So most people report that they received an opioid from a friend or family member as their first use of an opioid. And that's kind of scary to think we're writing these prescriptions that are then being dispensed from the patient to a friend or family member, and that person eventually goes on to become a heroin user.
So what I'd like to know then is, at times, a practitioner is going to need to set some kind of a limit with a patient. We're talking about sort of how to taper and what other alternatives they might offer. At some point, a patient may be asking for something that a practitioner just doesn't feel comfortable doing, and the easy thing would be to write the prescription, but ethically, according to the guidelines, practice standards, it doesn't seem like the right thing to do. And that's the interaction that I think our primary care practitioners are finding really difficult. So what kind of thoughts or hints do you have to help with that when it does come time to set a limit?
Yeah, my approach is really to sympathize and commiserate with the patient. Just like how we have a discussion about patients coming in with an upper respiratory infection who ask for antibiotics, and we have to tell them that they don't need antibiotics.
Very similar. Yes.
Very similar in some regards. I will say, I would love to prescribe these medications for you if I thought they were going to help. Unfortunately, opioids have not been shown to help for chronic headache or chronic back pain or whatever the indication is that the person wants them for. As much as I'd love to give you these medicines, they're just simply not going to work for this indication. And so I like to commiserate with the patient that I wish I could give them these medicines, but they're not going to help. The other tack that I take quite frequently is to explain that national guidelines no longer support the use of these medicines, and that not only are they not going to help, they may actually harm that person.
And so you would actually talk about the fact that the guidelines have changed and that they might have heard something different at one time, but this is what we know now. It's new scientific knowledge, essentially, that we want to do what's right for them according to the best available knowledge.
Yeah, absolutely. Again, I would say I would love to give you these medicines. Unfortunately, I think if I do prescribe these medicines in the way you're requesting, there's a very high likelihood, a significant risk that you're going to die from these medicines. Or if you don't die, that they're simply not going to help you.
Not gonna help.
And at the same time, I could be censured for doing this since it's not considered the standard of care any longer for how to manage these medicines. And if I do that, I'm at risk of losing my license and jeopardizing the care of the other people in this practice.
And do you find that patients can sort of see that from your point of view?
I think they can. They don't necessarily always agree, but they can at least appreciate it and respect that opinion.
Okay, so it's maybe sometimes an agree to disagree, but they can understand where you're coming from and it doesn't feel punitive, like you're doing this personally.
Exactly. There's no finger wagging. There's no, I'm not going to give you these medicines because you're an addict.
Right.
There's no, you're doctor shopping or you're drug seeking. I try not to use any pejorative terms there. And it really becomes about it ultimately boils down to what is an appropriate risk versus benefit ratio for these medicines.
So that's where I think motivational interviewing can probably help, is just to keep things respectful and to be able to put things out there without it being blaming or stigmatizing, not calling people an addict, those sorts of things.
Exactly. As you know, one key component to motivational interviewing is normalization. That, many people are on these medicines, people use them for various things, and you normalize their behaviors of using these medicines, maybe even of seeing multiple providers for these medicines, and you don't judge them on that. At the same time, you set some pretty significant limits and explain to them what you're unable to do because it's simply not effective and not safe.
Sure. And I think some of those conversations are likely to go better than others. So we've shown a video that shows a relatively challenging patient situation where the patient is getting medications from multiple practitioners and calling in between scheduled visits, and it's a pretty difficult interaction in the video. But our trainees have said they really didn't think that patient was difficult enough. Because, for instance, he didn't threaten to sue the provider, he didn't make a threat of violence against the office staff, he didn't do sort of some of these extreme things that I think providers are really kind of scared of. What advice would you offer to somebody in that kind of a scenario?
Well, and something that is maybe not addressed in that underlying conversation is that patients will go to great lengths to not go through withdrawal. So when you take a patient who is dependent on these medicines, physically dependent, in that case maybe has a very abnormal relationship with the drugs, they will do whatever it takes to not have withdrawal symptoms. And it's very difficult to convince them that they have an opioid use disorder in the first place, because they know when they don't get their medicines, their pain gets worse, their anxiety gets worse, they sweat, they feel terrible. They don't recognize that as withdrawal symptoms. They recognize that as you not being willing to give the medicines to them, even though these medicines clearly work for their pain. Their pain gets better when they take the medicines. Their anxiety gets better. Their nausea gets better. And so a lot of times you really have to call them out on the fact that, look, I think what you're actually having is physical withdrawal symptoms, and we can actually help you with that. I want to know, I'm going to support you with that. We can treat that with medications, and I'm going to do whatever I can to keep you comfortable at the same time that you still set those limits. So there's that aspect to the physical withdrawal of the medication.
The physical is they feel sick, they want a medication to treat that, but this isn't the right treatment. It's just they're preventing withdrawal at this point.
Yes, but as providers, we have to recognize that withdrawal symptoms are very severe and really unpleasant. And I think we really under-recognize that in primary care as a driver of a lot of the negative behaviors we see out of patients. The patient getting very angry, threatening your front desk staff, calling a bunch of times when their refills are late. That's a lot of times withdrawal-mediated symptoms. Even if it's not withdrawal-mediated, I think we all have to get comfortable with difficult patient interactions. And you have to know, even if you're up on your motivational interviewing and your CBT and any other psychologic techniques, some visits just aren't going to go well. And you have to recognize that patients might try to manipulate you, and you can set hard limits. And even if that's 1 in 10 patient encounters, it's not about you, it's about them, and you can still set limits and feel like you did the right thing.
So I think there are some situations where just doing the sort of education we're talking about and recommending alternatives, that's going to help, right? Mm-hmm. There are some situations where maybe what you need to do is see this is not a difficult patient, but a patient who's struggling and going through withdrawal, and sort of reframing it that way and treating it that way might help. And then there's still going to be some subset of the very difficult encounters. It's going to be fewer if you've done some of these other things, if you're using the motivational interviewing, but still to have a strategy for how to deal with those more difficult scenarios.
Yes, absolutely. And one thing we didn't talk about is the fact that opioids actually treat a whole host of psychologic symptoms. So opioids are anxiolytic. They reduce anxiety. They actually create euphoria, so they, in the short term, can help depression symptoms. They even have antipsychotic properties. So a lot of patients are actually self-medicating with opioids for other psychologic conditions. And we know pain has a very strong psychologic component. So exactly the kind of people who are the most likely to be on chronic opioids, this concept of adverse selection, people who most likely wind up on chronic opioids are precisely those who already have underlying substance use disorders or psychiatric illness, or major mood disorders.
Health issues, yeah.
Exactly. And so we're seeing them, we're having the conversation about pain, but what it really is they're using the opioids for their sleep or anxiety, and we're not addressing that. So we have to also recognize that that can be a driver of the difficult conversation.
So some of it is if we identify a different problem, it's not about pain, it's about anxiety, it's about sleep, it's withdrawal symptoms. Maybe we could actually treat some of that, and patients would be more amenable to work with us then in terms of reducing the opiates.
Yeah, absolutely. Once again, it's using those motivational interviewing techniques, it's about normalizing, saying to the patient, I understand that sometimes people use these medicines to help them sleep at night or to reduce anxiety, and they're very effective. Do you sometimes do that? So you can elicit what they're using the medicines for that way. You can also start by having a conversation about the fact that all pain has an emotional component, that when you sense pain, it goes up through your thalamus and your brain, and then in addition to going to the sensory cortex, also goes to the emotional centers of the brain. So there is no pain without having an emotional component as well. And ask them what their emotional response is to their pain. Because a lot of times they're treating psychic pain with these medicines, and they have a lot of anxiety around their pain. So that can help to identify the underlying conversation as well.
But people are also resistant to this idea that it's all in your head.
Right. They're resistant to it. At the same time, I think with good explanation and not being pejorative, they can understand that pain is all sensed by the brain. If you didn't have a brain, you wouldn't have pain in the first place.
So something else I wanted to ask you about is the use of behavioral contracts, in which you might specify what you're going to do and what a patient's going to do or not do, not get medications from other prescribers and only on a certain schedule take it as prescribed, that sort of thing. What's your opinion about that sort of a practice? How well does it work? Do you use it?
I like to use the contract as a way to really outline reasonable expectations with the patient, that these meds only work in about a third of people who take them. And if they work, they're only going to lower your pain by maybe about 30%. And if you don't respond to them, within at the most 3 months, we're going to taper you off of these medicines. And then all the other issues that we go over, using one pharmacy, going to only one physician, that you might undergo urine toxicology testing if necessary, if we have concerns about appropriate use. All those are things that I think are an opportunity to highlight both how these medicines are not a panacea and how they're actually dangerous and we need to monitor them.
And then what if a patient does violate the contract, if they don't uphold their end of the bargain?
So I think it really depends on the type of violation. There's what we call kind of major red flag behaviors and maybe more minor aberrant behaviors. If someone is violating the contract by doctor shopping and getting full prescriptions from 4 physicians, that's an automatic terms for dismissal. If someone is forging your name on a prescription, that is another thing you would never continue to prescribe. But if someone maybe is coming in a few days early for their medication refills or calling your office frequently, these are minor behaviors that need to be addressed by maybe figuring out a little bit more what's going on, asking them what's happening in their life, addressing what other stressors they might be experiencing, and then maybe responding by monitoring them more frequently, providing a little more education. So it's not necessarily an automatic dismissal. We don't use the contract as a way as like an aha or gotcha moment where you can finally get the person off of opioids. We look at it as a way that you might address these and try to really figure out what is really going on with the person's life before you decide how to respond.
Well, and if there is that sort of a major violation, if they're forging your signature, for instance, you're, dismissing them from care is not going to get them off of opioids. It's going to send them someplace else or to street drugs or something like that.
That's right. And even if you're taking someone off of opioids because, let's say, they have a persistently positive urine toxicology test for cocaine, it's not really going to do them a service for you to point your finger at them and say, you've been using cocaine, I need to get you off these medicines, you need to get out of here. It's really addressing that this person has a use disorder and they need treatment. And so I always medicalize that by saying, I see that it seems you seem to be struggling with cocaine use, and then asking the questions to diagnose a use disorder, and then trying to maintain them in care and saying, I can't prescribe these opioids for you anymore. It's not to the standard of care. However, I want to continue to treat your pain, and I want to address your cocaine use disorder. So I want to refer you to substance use treatment services. But at the same time, you're giving the person support and saying you want to continue to be their primary care provider.
So you would set a limit with regard to the opioids, but you still then wouldn't necessarily dismiss the person from your practice. You would still work with them and try and work through the other issues that they're facing. You just might not agree to prescribe them any more opiates at that point.
Exactly. I think it's perfectly reasonable to not prescribe them more opioids, but we need to do whatever we can to keep them engaged in our practice, because the worst thing you can do is dismiss the patient and then just have them go shopping around through the medical system for the less scrupulous doctor who's just going to resume their opioids and not address their underlying addiction.
That makes sense. Okay, so I want to close by asking you something that I've heard, especially from some of our pediatric colleagues, about the potential for undertreating pain. Because I think their perspective is this pendulum has sort of swung on pain medication from the 90s when we were saying we're really undertreating pain and we need to do more with that, to now when we're very concerned about misuse of prescription opiates and maybe overtreatment. And so the concern is, are we leaving some people out who do have legitimate pain needs, and are we actually still undertreating? What would a more reasonable solution look like to this problem of pain?
Well, I think the pendulum is still in the process of swinging far back to the less prescriptive or less liberal prescribing practices, and I think it needs to. We still have a long way to go in terms of addressing the overuse of opioids in society. We need to re-educate physicians to prescribe less and re-educate our patients that they should expect less because these are simply not effective. But who will get pinched in the end are people with legitimate pain concerns, particularly people with acute pain and maybe special populations like kids. The problem is we've created such an epidemic that now the pendulum really does need to swing further towards the more conservative prescribing before we can maybe hit a level of equipoise, a level of balance. But I do think it's legitimate that people in pain are going to be left suffering because of the chilling effect we've seen with opioid overdose deaths and the need to prescribe less. Eventually, it's not going to be about prescribing too much or too little. It's going to be about doing an individualized risk-benefit assessment for each patient and determining whether they're a good candidate for opioids. And certainly, kids in pain, in acute pain or severe chronic pain from a bone cancer or something like that, should have their pain very aggressively treated.
So it sounds like that's, if we were to envision a future system where we're sort of not having this pendulum go back and forth and just a more reasonable approach to pain overall, would be more individualized, more based on risk assessment, what the person's actual medical condition is and their needs.
That's right. It's really not about prescribing too little or too much. It's about is that person likely to benefit? Do the benefits outweigh the risks? And ultimately, does the person have an indication for which an opioid is likely to be effective?
Great. Well, Dr. Bloom, thank you very much. I enjoyed this conversation. I appreciate your expertise.
Thanks for having me, Dr. Cook.